Next topic is tuberculosis of the hip joint. After the spine, hip is the most common affected bone in tuberculosis. The pathological features are: most commonly it is seen at the acetabulum or the head of the femur. Quickly the articular cartilage and the bones are affected. The cartilage are destroyed and thus the joint is full of pus and granulation tissue. The synovium will get thickened, edematous, grayish and ulcerated. The bone ends becomes raw. There will be multiple cavitations which are a pathognomic feature of this tuberculosis. The head or the acetabulum will get partially absorbed also. And this is the cavitation seen in the tuberculosis of the hip joint. The head may be lying out of the acetabulum in a pseudo-acetabulum on the ilium, and that we call as wandering acetabulum. See, this head has necrosis, caseating necrosis. This head is lying in a pseudo-acetabulum somewhere in the ilium, and thus this acetabulum is empty, and this is known as the wandering acetabulum. And what are the clinical features? There is cold abscess in the groin or at the greater trochanter, and that will discharge as a sinus. In children, the child becomes apathic and pale. There is loss of appetite. There will be stiffness of the hip and there will be a limp. There will be night cries. Why? Because due to rubbing of two diseased surfaces at the night, there is muscle relaxation during the sleep, and that causes this rubbing, and that causes the night cries. On examination, there is lameness. There will be lumbar lordosis, which are more prominent as a compensatory mechanism to the flexion deformity at the hip. There will be a stiff hip gait. There will be muscle wasting, discharging sinuses are seen, deformity and swelling are noticed, there is shortening and also movement restriction. Stages of this TB hip. Stage 1 is stage of synovitis, stage 2 is stage of arthritis, and stage 3 is stage of erosion. There will be flexion, abduction and external rotation attitude of the femur. In investigation, radiological findings are: there is haziness, irregular outline, the joint space is very much reduced, there are lytic lesions seen, and there is acetabular changes that we have seen as wandering acetabulum, and there are signs of healing with the areas of sclerosis. The treatment is stage 1 and 2 requires conservative treatment with care of hips and general care like ARTs, rest and mobilization. Stage 3 and some of the stage 2 requires operative treatment. Operative treatment are joint debridement. We are debriding all these necrotic areas. There is another option, girdle stone arthroplasty. The head and the neck are removed and then arthroplasty is being done. It seems to be like this. The neck and the head which are affected are removed and we are joining this part, and the movement is again restricted. Other option is arthrodesis. The cases where stiff hip in a functional position is more favorable or suitable. So we knock out the hip joint completely, and that is the arthrodesis. Other option is corrective osteotomy, and finally the total hip replacement with prosthesis. And that's all about this tuberculosis of the hip joint. Another small topic is Coxa vara. What is that? That is reduced angle between the neck and the shaft of the femur. It is either congenital or acquired. This is the diagram or the figure. The bone appears like this. Usually this angle is more than 90 degrees. Now the angle is reduced between the shaft and the neck of the femur. There is a term infantile coxa vara. It is a growth anomaly at the upper femoral epiphysis, and there is a painless limb in the child just started walking, and there is shortening of the limb, and the abduction and internal rotation of the hip is limited due to this reduced angle. The radiological findings are: there is reduction in the neck shaft angle. This is the angle. It is almost 90 degrees. Epiphyseal plate is too vertical. The epiphyseal plate is almost like this. It is too vertical. There is one term called as the Fairbanks Triangle. It is a separate triangle of the bone in the inferior portion of the metaphysis. This is the Fairbank Triangle. This triangle is a pathognomic feature of this Coxa vara deformity, and that is in the children more especially. Treatment is subtrochanteric corrective osteotomy. Just below the trochanter, we do an osteotomy. We cut a piece with the lateral wedge as the base. So it increases the angle between the neck and the shaft. This is the X-ray showing the Coxa vara in adults. It has fused and it is almost 90 degree, and the epiphyseal plate is almost vertical. Next lesion is the slipped capital femoral epiphysis. The upper femoral epiphysis is displaced at the growth plate. Most commonly posterior medially it is displaced, and that causes the Coxa vara, and it is gradually seen in most of the cases. See, this is the epiphysis of the femoral head, and that is slipped from the growth plate, and it is mostly posteriorly and medially shifted or displaced. The causes are not exactly known, but mostly by trauma, more commonly in unduly fat and sexually underdeveloped people, and in tall, thin, sexually normal children. Clinical features: age mostly in puberty, most common in boys, and 30% only it is bilateral. There will be a history of trauma, and commonly there will be an endocrine abnormality. There will be pain in the groin, and it is seen radiating to the thigh and the knee, and there will be a limp. On examination, the joint is externally rotated. There will be a short limb. Shortening of the limb around 1 to 2 cm is seen, and there is limitation of abduction and internal rotation, so it is almost similar to the Coxa vara, with more attitude of adduction and external rotation. Radiological findings: the lateral view is the best, with angulation between the head and neck are seen clearly. The AP view, we can see Trethowan sign. What is the Trethowan sign? Line drawn superior surface of the neck remains superior to the head. This is the Trethowan sign. The line drawn superior to the neck remains superior to the head, whereas in normal cases the line bisects the head. In normal cases the line bisects the head. The line drawn superior to the neck bisects the head, whereas here the line drawn superior to the neck passes superior to the head also, and this is the Trethowan sign. Regarding the treatment of the acute slip, we can do a close reduction and pinning. In case of treatment of gradual slip, if less than 1/3 diameter of the neck of the femur is slipped, we can fix it internally in situ. If the slip is more than 1/3 of the diameter of the neck, then corrective osteotomy is the only possible way. And treatment of the unaffected side, we have to take a prophylaxis, and as 30% of the cases are bilateral, prophylactic pinning must be done. Next is congenital dislocation of the hip, CDH, also known as the dysplastic hip. It is the spontaneous dislocation of the hip at, before, or during, or shortly after the birth, and it is uncommon in India. Why? Because in India, the mother used to carry the child in her hip, and that helps in proper traction or manipulation of the hip joint and clears or reduces the possibility of this congenital dislocation. Etiology: hereditary predisposition to the joint laxity is an etiology. There is a hormone-induced joint laxity in case of breech malpositioning. Two types of dysplastic hip are seen. First one, those dislocated at the birth, and that is the classic congenital dislocation, and it is difficult to treat. Why? Because of the hereditary faulty development of the acetabulum. Whereas the second type is those dislocated after the birth, that is mostly due to joint laxity and with some of the predisposing factor, and that is less difficult to treat. The femoral head is dislocated upwards and laterally. This is the child's X-ray. See, the femoral head is dislocated upwards and laterally. In this X-ray, the acetabular cavity is shallow and there is delayed development of the head of the femur. The other features are the acetabulum is shallow that we have seen. The capsule of the hip joint is stretched and the muscle around the hip will have an adaptive shortening. See, the femoral head is dislocated upward, the acetabulum is empty and it is shallow. Clinical features: it is more common in first-born babies. The reason we don't know. In early childhood, there is asymmetry in the creases of the groin. There is limitation of the movement of the affected limb. Click is heard every time the hip is moved, and these features are noticed by the parents. In older children, there will be peculiar gait without any pain. For examination, we can do two tests. First one is the Barlow's test. And in Barlow's test, there are two parts. The first part is the knees are fully flexed with the hips at 90-degree flexion. The hip is gently adducted. This is the Barlow's test first part. Initially, the hips are flexed at 90 degree and it is adducted. We have to look for any abnormal posterior movement along with the clunk. If it is noticed, then the dislocation is present. If it is not heard, there are two possibilities. Either it is a normal hip or the hip is already dislocated. In the second part of the Barlow's test, with the hips at 90 degree and full adduction, the hips are gently abducted. So in the opposite direction we are performing this, and it is the Autolani test. The second part of the Barlow's test, if we are performing that alone, it is known as this Autolani test. In the opposite direction we are abducting. So again, if we hear a clunk, it means the already dislocated head has gone into the normal position. So we are reduced it properly. So that's why we are hearing a clunk. If we are not hearing a clunk, either it is a normal hip or it is an irreducible dislocation. If we are hearing a clunk, it was dislocated. Now it is reduced properly, and that's why we are hearing a clunk. If it is not, either it can be a normal hip or it is an irreducible dislocation. This second part of Barlow's test itself is the Ortolani test. Second one is the Ortolani test, and it's the second part of Barlow's test. Hips and knees are at the flexed position, gradually abducted. If we are hearing a click on the entrance, it is a sign of reduction of the head into the acetabulum. The third one is a Galeazzi sign. The levels of the knees are compared at supine position with the knees flexed and the hips flexed at 70 degree. See, this is the Galeazzi sign. So what we can see, there is a lowering of the knee on the affected side. This side is affected. So while we compare the knees at the supine position with the knees and the hips flexed, there is a lowering of the knee on the affected side, and that is the Galeazzi sign. The last test is the Trendelenburg's test. Standing on the normal limb, usually opposite side anterior superior iliac spine will be at a higher level, and that is in case of a normal limb. This is the normal limb. Standing in one leg, the opposite side anterior superior iliac spine will get moved upwards, and that is a normal phenomenon. But if you are standing on the affected limb, the opposite side anterior superior iliac spine will get at a lower level. It dips down. This is the affected limb, and if you are standing on the limb, then the opposite side anterior superior iliac spine will get down into a lower level, and that is just opposite to the normal case, and this is the Trendelenburg's test positive. And the radiological findings, there is a sloping acetabulum noticed, the lateral and the upward displacement of the femoral head is seen, and there is a break in the Shenton's line, and there can be a delayed appearance of the ossification center of the head of the femur. This we have all seen. And next is the methods of reduction. First one, there can be closed manipulation under general anesthesia, which is the most effective treatment. Second is traction followed by manipulation, and third option is open reduction only if closed reduction fails. Next is we have to maintain the reduction. It can be plaster cast, and that even two types. Frog leg cast, this is the frog leg cast, and second is the Bachelor cast. This is the Bachelor cast, and in all this the thighs are abducted. Second is the splint. Von Rosen splint can be used, and this is the splint, and this is how the child looks like after the splint has been put. And next are some acetabular reconstruction procedures. The first one is the Salter's osteotomy. The roof of the acetabulum is rotated with the pubic symphysis as the fulcrum. This is the pubic symphysis, and the roof of the acetabulum is being cut, this portion, and it becomes horizontal after rotation. This is the pubic symphysis, and with this point as the axis, the whole thing is rotated in clockwise direction. So this acetabulum becomes a more horizontal and a more roof-like structure is produced. Acetabular cavity deepens, and this prevents further dislocation. And this is the Salter's osteotomy. Second is the Chiari's pelvic displacement osteotomy. Just above the acetabulum, it is cut and it is medially displaced. Just above the acetabulum, it is cut, and this portion, acetabular and its lower part, the bone, it is being displaced medially. Again, the roof is extended, and this cavity is again becomes broader and deepens, and this again protects its displacement in the future. Pemberton's pericapsular osteotomy. The roof of the acetabulum is deflected downwards over the femoral head. See, this is the roof of the acetabulum. It is deflected. Again, a bone piece is being kept into it. So the roof is deflected downward over the femoral head. So the cavity of acetabulum deepens, and it again covers this head and protects it from further displacement or dislocation. And these are the acetabular reconstruction procedures. And this is the end of this topic.